Hi, everybody. My name is Emily Meehan. I'm a kinesiologist from Nova Scotia, Canada, and I'm working as a life coach with an after-school program for children with autism and other diverse needs.
Hi, everyone. My name is Olivia Meehan. I live in Nova Scotia, Canada, and I currently work as a school-based speech-language pathologist.
Hi, my name is Danielle Fritz. I live in Coldwater, Ohio, and I'm currently a 7th and 8th grade MD special education teacher.
Hi, everyone. I'm Nicole Coer. I live in Powhatan Point, Ohio, and I am an RBT at an ABA center in Wheeling, West Virginia.
Hello, my name is Dario Arboleda. I am a RBT living in Evansville, Indiana, and working in a clinic for children diagnosed with ASD and other special needs.
Hi, everyone. My name is Zach Ray. I'm a behavior therapist living in Lower Merion, Pennsylvania.
So, Dario, Danielle, and myself will be expressing the pro discussion for this debate. Using our own personal experiences and research found during the preparation for this debate, we have decided to support the use of restraints and seclusion for people with autism and other developmental diseases. We will share the information that we found and compiled that helped us make a decision on the complex and controversial matter. We feel that restraints and/or seclusion can be a positive strategy when working with individuals who have extremely aggressive behavior and are unsuccessful with strictly positive behavior plans. The use of restraints or time seclusion allow complex individuals to be included in typical education settings. It can allow for positive behavior treatment plans to be put in place and taught successfully, and it allows individuals, their staff, and their peers to all remain safe during the times that they spend together. One of the most important findings in our research is that the correct use of restraints and seclusions was often missing in the situations that were deemed unacceptable or unethical. Therefore, we completely base our own opinions towards the restraints and seclusions as if all the staff are trained professionally and are using strategies correctly and safely at all times. Not only does our opinion arise from research, it also aligns with the professional and ethical compliance codes followed by the BCBAs and other professionals working with populations with diverse needs and varying ability.
All right, so myself, Nicole, and Zach will be discussing the cons of the use of restraints and seclusion, particularly in those with autism spectrum disorder and other developmental disorders. Many individuals with ASD and other developmental disorders, such as attention deficit hyperactivity disorder, Williams syndrome, and communication disorders, to name a few, engage in behaviors that pose a risk to themselves and/or others. These behaviors manifest in many forms with different functions, such as hitting to gain attention or biting for automatic reinforcement. As a result of these harmful and undesirable behaviors, the use of restraints, whether physical, mechanical, or chemical in nature, as well as seclusion, have been and continue to be used in educational, recreational, and residential environments all around the world. As applied behavior analysis becomes more widely known and understood, the use of more effective and efficient strategies, such as proactive antecedent procedures, which may include offering choices or using highly preferred activities or items, is becoming more common. Despite this, however, overuse of and abuse resulting from restraints and seclusion continues to be documented. We feel our professional and ethical obligation is to not support the use of restraints and seclusion for individuals with ASD and other developmental disorders, as their use can result in injury and death, psychological trauma, and it is a violation of basic human, constitutional, and civil rights. These are risks that professionals should not be willing to take when working with this population, especially when more appropriate strategies, as documented in the literature, are available for use.
The use of restraints and seclusion are essential for the inclusion of all students with varying diagnosis in various settings, especially in public schools and other facilities. Many individuals benefit from the use of restraints and seclusion. Individuals with extreme or aggressive behaviors are often excluded from public schools and other facilities where other students and children may be present. Through the appropriate and correct use of restraints and seclusion, these students are able to attend public schools. They are even able to attend classes with their peers. According to Villani, Parsons, Church, and Beater, in a descriptive study of the use of restraint and seclusion in a special education school, schools cannot indefinitely suspend students or expel those with disability-related behaviors. The law required schools to develop methods that would safely manage aggressive or self-injurious children whose behavior was identified as a manifestation of a disability. With this being said, procedures must be in place to keep these children in the schools. Restraints and seclusion help to solve this issue and keep the students at school, even when they're displaying aggressive behaviors related to their disability. Adults and staff trained in the correct use of restraints and seclusion also see numerous positive behavior changes in the child with the extreme behaviors. These students with these behaviors do not want to face that sort of punishment again. For this, they do not continue to demonstrate these behaviors. Staff are able to help the child quickly put an end to the behavior and work on developing coping skills and strategies to deal with the cause of the behavior. One major goal of applied behavior analysis is to decrease problem behaviors and suffering. As stated in Applied Behavior Analysis, the second edition by Cooper, Heron, and Heward, for some clients, punishment-based interventions may be the only means of reducing the frequency, duration, or magnitude of chronic and dangerous behaviors that have proven resistant to change using positive reinforcement, extinction, or positive reductive approaches such as differential reinforcement or alternative behavior. Also stated in this text is that it may be viewed as unethical to not utilize some forms of punishment procedures that research has shown to be effective because it is withholding a potentially effective treatment and risks maintaining a dangerous or uncomfortable state for that person. They also state that punishment is a natural part of life. We can't strictly develop interventions and never consider punishment because it may be the one strategy that benefits the child. Another reason restraints and seclusion are necessary and positive for all is because they provide safety. Staff members are able to keep the student, other students, and the staff safe. Safety is a primary concern for all. The use of restraints protect the student from themselves when self-injurious behaviors are occurring. They are also able to keep other students or clients safe from that child. If the child is throwing objects or attacking others, the use of restraints will put an end to those behaviors and protect all present. Although some say staff risks injury when restraining, they're engaging in restraints to protect themselves. Far worse injuries could and would occur if there was no attempt to stop an individual from throwing things or going after others. Seclusion is also an option that would require far less physical contact between the staff and child. This would then lower the risk of injury to staff. Nonviolent crisis prevention interventions provides training opportunities on strategies to de-escalate situations and how to appropriately use physical intervention when needed. Training highly encourages staff to use de-escalation strategies as often as possible and only use restraints as a last resort. In the visuals shown, you're able to see the correct application of physical restraints to show the safety for children. If you see in the CPI transport position, there is no risk of cutting off oxygen or pressure put on the organs of the individual being transported. If you view the CPI team control position, there is also no pressure to cause injury. There is also a third person continually checking on the person being restrained in their physical state. Looking at the picture, I can't see them right now, they're too small. On the bottom, where they are holding the arms to try and prevent, there is also no pressure placed on the organs. In the child control position in the bottom left, you can see that the arms are strategically placed to allow the child in the restraint to continue breathing and not block the airways. When staff receives the proper training in restraint and seclusion protocols, there are many benefits. Students are able to remain safe. Staff is able to remain safe. There are positive behavior changes seen in the child that has been restrained or secluded. Students with aggressive behaviors are also able to attend classes in a public facility that they would otherwise be banned from. According to the compliance codes for applied behavior analysis, aversive procedures may be used as long as staff receives an increased level of training. Prior to the implementation of restraints and seclusion, staff receives specialized training in its implementation. Parents and guardians are also informed of the potential use of this strategy prior to using it. It is important to know your students and clients and what benefits them. Restraints and seclusions are not for the use of everyone in every situation. It is important to remain educated and up to date on proper holds and implementation.
All individuals that experience restraints and seclusion are at risk for injury and/or death. With this being said, children have a higher risk of death or serious injury. Students with disabilities often exhibit behaviors that are considered to be problem behaviors. The lack of understanding or accommodations toward these behaviors often result in restraint or seclusion. The Child Welfare League of America estimates that between 8 and 10 children die each year in the United States due to the use of restraints. Asphyxia is the most common cause of death when looking at the use of restraints. Positional asphyxia happens when an individual's body is positioned in a manner which restricts respiration. This type of asphyxia often occurs when an individual is placed in the prone position for a hold. A simple event, such as a minor flexation of the head into the individual's chest, can cause death to occur. A review of 63 cases that resulted in death by asphyxiation during restraint was conducted. Out of the 63 cases, 57 of them found that even though the restraint was implemented properly and correctly by trained staff, death still occurred. These findings show that restraints are extremely dangerous and life-threatening even when implemented correctly. Blunt trauma to the chest occurs when the forceful hit is delivered to the chest of an individual, which can happen while restraining a child. One case, which was legally prosecuted, showed a child received a blow to the chest while a restraint was being implemented, which resulted in his death. Blunt trauma to the chest is more likely to occur in children because of their thin chest walls. Thrombosis, which is a fatal pulmonary embolism, can occur during the restraint process and can result in death as well. Research shows that immobilization may cause thrombosis to happen. Immobilization is a key factor when using restraints. These are just a few of the conditions that result in death. Physical injury happens during the restraint process as well. This includes skin irritation, bone loss and breaks, stiffness of muscles, increased risk for respiratory infections, nerve damage, restricted circulation, contusions, and friction burns on the skin. Physical injury is not the only trauma that children with disabilities can experience from restraints and seclusion. This is especially true if these individuals have experienced some sort of prior abuse. Trauma-informed care literature shines a light on the issue that many individuals with disabilities have in fact experienced abuse in the past. Experiencing these issues can re-trigger the underlying issues. Such issues can be fear, anxiety, and rage. It has also been reported that children have reoccurring nightmares, intrusive thoughts, avoidance response, marked startle response, painful memories, and fearfulness of seeing others hurt. Individuals can also have a huge mistrust of adults. Children can feel humiliation and loss of dignity, which can diminish their quality of life. Restraints and seclusion can cause a child with disabilities to withdraw and isolate themselves. This can also lead to the child becoming hostile and aggressive. Behaviors such as these will be seen as problematic behaviors, which in turn will continue the cycle of misunderstanding. When other interventions which are positive are used instead of restraint and/or seclusion, then the opposite psychological effects occur. Individuals feel increased self-esteem and dignity. They have an improved quality of life. They want to take part in socialization and group activities, and they have the motivation to change the problem behavior. This is the outcome that we want for all children and can only be reached if restraints and seclusion are replaced with positive interventions. There are currently no federal laws in the United States that prohibit schools from administering restraints and seclusion. State laws also vary greatly. Students with disabilities served under the IDEA Act make up only 12% of the student population, but 58% are placed in seclusion, while 75% of these students are restrained at school. The International Covenant on Civil and Political Rights state that excessive restraint in school is cruel, inhumane, and degrading treatment. The United Nations Convention on the Rights of Children have set forth guidelines for the rights of children with disabilities. There are also many ethical principles that restraints and seclusion go against. The first is to do no harm. As stated, both physical and psychological harm has occurred from the use of these strategies. By not teaching these students replacement behaviors and instead restraining/secluding them, we are not respecting their autonomy. Being just means to treat others the way that you would like to be treated, and in many situations, this just isn't the case. Restraints and seclusion do not promote treatment that allow individuals to be treated with dignity or respect. This goes against according dignity. Accepting accountability ensures that treatment being provided is proper and just, which restraints and seclusion is not. These also tie into our ethical codes. As the slide shows, do no harm aligns with Compliance Code 1.0, Responsible Conduct of Behavior Analysts. Respecting autonomy aligns with 2.0, Behavior Analysts' Responsibility to Clients. Being just aligns with 4.0, Behavior Analysts and the Behavior Change Program. According dignity aligns with 6.0, Behavior Analysts' Ethical Responsibility to the Profession of Behavior Analysts. And accepting accountability aligns with 9.0, Behavior Analysts and Research, and 10.0, Behavior Analysts' Ethical Responsibility to the BCBA.
Seclusion and restraint should only be administered as a last resort and only when less restrictive interventions will be insufficient to prevent serious harm. When dealing with a behavioral crisis, it is fundamental to choose the least coercive approach to de-escalate the patient's behavior and secure their safety and the safety of everyone around them. All physical restraints must be applied correctly by trained individuals, using compliance with relevant laws, regulations, policies, and the BEACB Professional and Ethical Compliance Code. Most of the cases where restraint and seclusion cause injury or harm involve undertrained staff, feeling of guiltiness and lack of preparation from the staff crew, as well as a lack of a structured guideline on how to implement these procedures. Abuse and mistreatment often happens because the personnel is not sufficiently trained in behavior management procedures. Every professional and paraprofessional working with clients that can potentially engage in aggressive behaviors should be trained and learn a comprehensive set of skills that can replace practices that might otherwise lead to abuse. Physical restraints are not meant to be used as a standalone technique to reduce a patient's behavior. These procedures are only meant to be used as part of an interdisciplinary approach that includes assessment, evaluation, and creating strategies to service the patients in the most humane and respectful manner. During the last 15 years, mental health workers and clinicians have raised concerns about the risks and dangers of physical restraints and seclusion. At this time in the United States, particularly with children and in nursing, restraint was viewed as the end result of a coercive interaction that was seen to initiate the aggressive response view that popularized reduction via staff training in de-escalation techniques. More recently, restraint use is increasingly being seen as an emergency procedure more than an intervention when it comes to handling aggressive behavior. Nowadays, there are companies that specialize in training mental health providers with preventive, evidence-based, and safe interventions. Even when alternatives to restriction and seclusion have strong scientific evidence that supports their implementation, the reality of inpatient treatment is that some children present particularly difficult management issues, and some patients may have issues with regulation, which puts them even at a greater risk. Alternative techniques are strongly encouraged. After all, it is much better to prevent behavioral incidents than to have to manage them. But if all of these methods were to fail in controlling a behavioral crisis, the staff should be ready to correctly implement restraint and seclusion methods in order to avoid serious bodily self-harm or harm to others. In conclusion, restraint and seclusion procedures have been misused for decades, and in consequence, there is a stigma when it comes to implementing them. There is no doubt that physical holds have a great potential to injure a patient physically, mentally, or even emotionally. However, avoiding them, even in emergency situations, will deprive mental health workers of a powerful resource that can potentially protect the patient and themselves from even greater harm.
For both parties involved, but it's unethical as well. Injury and even death is a major concern and a possible outcome when restraining students. Even when a staff member is trained, it must be taken into account the student reacting differently and being in different contortion positions compared to what may be taught in training. This can lead to the following questions. Did the training simulate live situations? Can the size and strength of an adult become a negative factor in high-pressure situations? Will the staff member impulse their own anger during these high-pressure situations? An article entitled 70,000 Students with Disabilities Secluded, Restrained in Schools, written by Education Weekly on May 16, 2017, stated the following. 1 out of every 100 special education students was restrained by school personnel or secluded in school from his or her peers in the 2014 school year, presumably to quell behaviors that teachers considered disruptive or dangerous. That means nearly 70,000 special education students were restrained or secluded in that school year, the most recent for which data is available. For most students, this happened to be more than once. States reported that more than 200,000 such incidents, so on average, a special education student was restrained or secluded about 3 times a day. These statistics, based on analysis by the Education Weekly Research Center of Data Collection by the U.S. Department of Education's Office for Civil Rights, represents the best national snapshot of the controversial practices. The numbers are almost assuredly dramatically understated as well. Recently, the issue has been made into a federal policy. States must explain how they plan to reduce adverse behavior interventions under the state plans that are required by every Student Succeeds Act, which was passed in 2015. Several of the 16 plans submitted so far refer to supporting school districts as they implement positive behavior supports and interventions, a framework to prompt good behaviors. None of the plans submitted so far spell out a restraint or seclusion threshold that would trigger further state interventions or to reduce the numbers. It was made clear in the statement above that there's a concern about having over 200,000 restraint situations each year. The more situations you have, the higher the likelihood of having a dangerous occurrence. This plays a key role in the idea of positive behavior plans. A 16-year-old autistic student, Brendan Long, was left with 2 shattered thigh bones after being restrained in his Louisville school. What happened to Brendan Long, who is now 18, has yet to be fully explained. No criminal charges have been filed in the matter, but the investigation continues. School staff members have said that Brennan was aggressive on the day that he was injured and taken to the ground by an aide in a procedure that nudged the student off balance and allowed him to be lowered to the floor in a seated position. However, Kentucky Protection and Advocacy, a federal mandated agency that represents people with disabilities, said that the behavior the staff members described, such as making loud noises, getting up from his chair, biting his arm, putting his hands in his pants, were not aggressive, and the restraint had been more forceful to cause such serious injuries. The aide that restrained Brennan remains employed by the district. However, the Long family ended up settling with the school district for $1.75 million and continue to speak out on the case. This case regarding Brennan Long is a prime example of how even when trained, serious damage can be caused when adults are matching force with force. A researcher named Lanza, who works closely with behavior and students with disabilities, mentions that staff members really mean well, but what they see as therapeutic intervention may in fact increase frequency of aggressive behavior. The staff's unconscious response to violent or abusive behavior may be exactly what the patient is seeking: attention, concern, and individualized care. The patient who sets out to attain these things will perceive the delivery as a reward. Thus, caregivers who provide these rewards to a client, believing that they are being therapeutic, may in fact be encouraging rather than discouraging violent behavior. Students may be doing this behavior in order to be secure. This would cause rewarding of negative behavior, as Lanza mentions. A self-injurious student may feed off of being restrained because they like the pressure and force provided by the people doing the restraining. Another area of concern is the post-traumatic stress disorder that can be related to restraints. As Dr. Herb Lovett observed, people who have been hurt in the name of therapy may not understand the flight any differently than survivors of cold abuse or sexual abuse. A common feature of post-traumatic stress syndrome is the flashback in which a person acts as if the memory is present reality. Every time they recall their previous maltreatment, unless their panic and rage are recognized as a function of stress, they are likely to be further stigmatized as impossible to serve. This is another area in which we must be concerned for the welfare of a child. A traumatic incident could cause long-term and even permanent damage. When not done correctly, restraining a child can cause harm to yourself or to the child. Not only can it cause harm and potential PTSD, but restraints does not allow for other techniques to be implemented, therefore not allowing development and growth. As educators, we want our students to be safe, grow, and develop, and by restraining students, we are not giving them these rights.
In closing, we've heard issues with restraints causing bodily harm, even when used as a last resort. We've also heard of mental trauma that long-term use can create. The most important point to reiterate is that restraints and seclusions are being used as a last resort, not for every problem behavior. They are being used as a necessary response in conjunction with positive behavior plans and teaching replacement behaviors in the perfect scenario that we are supporting. There are always risks with interventions when complex behaviors are involved. That is why following an ethical code where we are able to make the best decision for each client is important. We have to remember that many complex individuals are unable to respond to positive behavior plans singularly and need a combination of interventions to be successful. We agree that the changes in federal law are necessary, but they should not be focusing on removing restraints and seclusion. They should be focusing on increasing the requirements involved with restraints and seclusions. Demanding schools to have professionally trained staff will improve not only the safety of all involved, but it will also reduce the negative associations of both physical and mental problems that come with incorrect use of restraints and seclusions, allowing schools to become a more successful place for the children.
As Nicole stated and Zach reiterated, there are several issues at hand when considering the use of restraints and seclusion with individuals with ASD and other developmental disorders. First and foremost, there is a risk for injury and/or death. While Danielle commented that proper training and implementation will help prevent this from occurring, research looking at particular cases suggests otherwise. In one study, proper training and implementation was documented in 57 of 63 cases, which resulted in death due to restraint. What does this tell you? Imagine the risk when individuals are not properly trained or are trained but do not implement restraints properly. As a parent, how would you feel hearing this, knowing that your child could very easily become a part of this statistic? Secondly, the psychological impact of both restraints and seclusion can be debilitating, ranging from fear, anxiety, and rage to post-traumatic stress disorder. Many individuals with disabilities are already at an increased risk for mental health problems. Why further increase this risk? Positive behavior supports are far more effective in improving one's quality of life, both physically and psychologically. Finally, basic human, constitutional, and civil rights must be considered. As Nicole outlined, there are several codes from the Professional and Ethical Compliance Code for Behavior Analysts, as well as core ethical principles, which are violated when restraints and seclusion are utilized. Individuals with ASD and other developmental disorders have rights, including those outlined in the Individuals with Disabilities Education Act, and we as professionals have obligations. Restraints and seclusion do not align with these.
Okay, now we are going to answer the two questions that were provided to us to focus on at the end of our debate. The first question is shared on the screen. Are there any strategies or methods that can help improve, training for administering restraints or decrease the needs for restraints? As a group, we decided on a question based on our own opinions as an answer, and we believe that there is a need of requirements to have a ratio of trained staff for all the individuals that are in your organization, whether that be a school or a nonprofit program or a personal private practice. It's important to have a ratio of professionally trained staff for the amount of individuals that you have. We also believe that all trained staff should have annual MVCI or CPI training, whether you're in Canada or the United States, of 8 hours, and then a biannual refresher of 2 hours, just to make sure that we're all continuously learning in our practices and remaining as trained as we can be. As well as increasing the number of supervisors within our organization that are competent, not only trained, but have extreme experience in complex cases and are able to, mentor the newer staff that are trained so that they can learn the best practices to keep our kids safe, and continue to learn the practice de-escalation strategies that are also taught in MVCI and CPI training, as well as debrief. After each and every time that you use a restraint, all the situations are different, all of our kiddos are different, so debriefing with the group after a restraint is used is going to help us continuously learn and decrease the needs for restraints in the future.
All right, so question number 2 says, the use of restraints and seclusion vary from setting to setting. For example, in Indiana, mechanical restraints are not recommended to be used for people in adult services. Is it ethical to use this as a way to address behavior if it is not something that can be used across settings? What happens if a child has a mechanical restraint in one setting, but then moves to a new setting where that type of restraint is not involved? So we do not feel that is best practice to teach an individual a restraint and then have them become comfortable with it when it is not going to be generalized to real life and lifelong practice. Policies and procedures need to be consistent across the lifetime so that generalization and success is possible. If an individual learns to expect and regulate with a particular restraint, to have it change with the new environment would require a complete reset and reteaching of the de-escalation procedure, which could easily be avoided. This is consistent with Code 4.07 in the Professional and Ethical Compliance Code for Behavior Analysts, which states that when environmental conditions cause issues to arise, it is our responsibility to find a new solution. Thank you all for watching our debate. We look forward to hearing your responses and feedback.